Welcome to the webinar, Pharmacist and Naloxone, Opportunity to Save Lives. We're pleased to be with you to share important information about naloxone that you all will hopefully take back and implement in your practice settings. I'd like to start with introducing our speakers. First, we have Cathy Huie, PharmD, who's president of Brame Huie Pharmacy in North Wilkesboro, North Carolina. She is a fellow of the International Academy of Compounding Pharmacists and is a clinical pharmacist practitioner. We also have McKee, PharmD, who has a master's in hospital pharmacy and is a board-certified psychiatric pharmacist. Dr. McKee is currently with Community Care of North Carolina in Raleigh. And I'm Vera Reinstein, PharmD, a board-certified pharmacotherapy specialist, and I work with Alliance Behavioral Healthcare in Durham. Next slide. Our objectives today will include quickly reviewing the national and statewide trends on opioid overdose. Next, I hope you'll be able to understand key elements of the North Carolina statewide standing order for naloxone. We'll go into much more detail with elements of the standing order, such as identifying candidates, reviewing the products, and what needs to be included when you're doing ed. And lastly, we'll review best practices for naloxone dispensing. Next slide. So just as an executive summary, opioid overdose is a preventable side effect and predominantly caused by prescription opioids and kills, mostly unintentionally, 78 Americans every day. We have naloxone, which is a safe, non-addictive opioid overdose antidote for 45 years, and it's been used by laypersons for the past 20 years to safely and successfully reverse opioid overdoses. North Carolina's standing naloxone order allows pharmacists to identify patients at high risk for overdose, educate patients about overdose risks and the role of naloxone, and then dispense intramuscular or intranasal naloxone. The success of this naloxone distribution, which is one of the tools to help reduce the prescription opioid overdose epidemic, requires community pharmacy support. Next slide, please. Overdose statistics. I wanted to quickly review some of the national and state level statistics on opioid overdose. Next slide. I don't think it will come as a big surprise to anyone if you listen to the news that our country's in the midst of an opioid overdose epidemic that has claimed the lives of more than 500,000 people in the past 15 years. More people die now from from opioid overdose than from motor vehicle accidents. In 2014, opioids were involved in over 28,000 deaths, and opioids represented about 61% of all overdose deaths. 44 people in the U.S. die from a prescription opioid overdose. And when you're talking about non-prescription as well as prescription, including heroin, that's 78 people die every day. And keep in mind, this death is basically a preventable side effect to which we have an antidote. Next slide. So looking at North Carolina data, I wanted to point out that most overdoses, deaths, are unintentional. So in North Carolina, there were about 1,300 overdoses in the black on the top, and a little over 1,000 of those were unintentional. Even though there was a slight dip in 2010, that number keeps rising despite all the work that is being done to combat this problem. Next slide. So when we look at what are the actual substances that are contributing to most of these drug overdose deaths, knowing that most of the overdoses are unintentional and 60% of overdoses belong to opioids, you can see the dark purple line. Most of these overdose deaths are due to prescription opioids. The light green dotted line you can see on the bottom, heroin, was somewhat stable until 2010, and then we saw this big spike. And we'll talk about that a little bit more, but basically as we've paid more attention to this epidemic and we've tightened down on prescription opioids, those addicted have been moving to heroin. Next slide. So as you can see, when we're looking at the rates of unintentional or undetermined prescription opioid deaths compared to the rate of prescriptions out there, it's not rocket science here. The bigger the dots, typically the darker green you're going to see. So the more opioids that are out there, the higher amounts of death that we're seeing. Next slide. So the correlation between these high opioid prescribing rates and the high overdose deaths that we saw in the previous slide with dark green big dots definitely makes sense when you look at the SAMHSA survey data on drug use and health, which looked at statistics around illegal drug use in the U.S. So according to the survey, if you're looking at that, the big circle, the dark blue or purple and the green, for people who illegally use opioids, over 70% of them either bought, stole, or received the opioids for free from a friend or a relative. So then if you're looking at the smaller circle, and where did these friends or relatives receive the opioids, over 80% of them received it legitimately from one provider. So it just goes to show that if there are opioids out there, whether they were initially prescribed for legitimate reasons or not, they will be found and eventually abused. Next slide. As we've been tightening down on prescription opioids, that's left those patients that are addicted no choice but to go to heroin. And indeed, 4 out of 5 heroin users start with prescription opioids. Just like everything else, heroin is not what it used to be. It's now contaminated with fentanyl and even more recently with carfentanil, which is 100 times more potent than fentanyl. And basically this is something that's used to sedate elephants or horses. Besides heroin having the added risk of lack of control of potency, now these added impurities are dramatically increasing the overdose risk. So aside from heroin having all these impurities, in addition, as we're aware, heroin is administered intravenously. And obviously, when you have intravenous use, you have the need for needles and syringes. And these dirty needles transmit diseases. So I'd be remiss not to mention quickly pharmacist syringe sales. Next slide, please. So just wanted to remind you all, the North Carolina Board of Pharmacy as well as the American Pharmacists Association endorse pharmacists selling syringes. And this is nothing but a public health issue if you want to boil it down. Without clean syringes, patients, they won't stop using drugs, but what they will do is reuse and share their syringes, and that will lead to hepatitis C and HIV transmission and infection. According to, this is from a North Carolina Board of Pharmacy FAQ that I've referenced on the bottom, selling syringes does not increase pharmacist liability for encouraging illicit drug use. Selling syringes does not encourage illicit drug use in and of itself, and it does not lead to on-site drug injection and improperly discarded syringes outside in the pharmacy parking lot, for example. So this should be viewed exclusively as a tool to reduce HIV and hepatitis C transmission and infection. And just as a side note as well, syringe exchange programs were legalized in North Carolina this past summer. So we should be hearing a lot more about actually syringe exchange programs. So just keep in mind, 50% of hepatitis C is linked to lack of access to clean needles. And as pharmacists, we can have a big impact on decreasing hepatitis C transmission. Next slide. So finally, regardless of your ethical leanings around opioid use and overdose and substance use disorder, as a health professional, this opioid epidemic is a public health crisis also from a financial standpoint. So as you can see, this is a study that from 2013 that looked at costs from 2009, and they've estimated about over $37,000 cost per opioid overdose event, and that's looking at direct costs and even more significantly the indirect costs. CCNC on a state level in North Carolina looked at the numbers of Medicaid patients and actually found for ED visits an average per cost visit of about $2,600. And in the North Carolina cost of inpatient hospitalizations for unintentional poisonings in 2008 was nearly $1 billion. So this is not small change we're talking about. So no matter how you feel about this, the rising number of these opioid-related ED visits and hospitalizations and deaths is becoming a huge cost for the healthcare system in North Carolina and a huge toll on our society as well. I'd like to turn over to Jerry McKee.
So now we're going to switch gears and begin talking a little bit about the Naloxone statewide standing order, which was executed this past summer in July of June of 2016. Governor McKee signed the bill, and then once it was signed into law, Dr. Randall Williams, the state health director, executed the standing order, which we will talk about in detail. Just a little bit about a standing order in general. The intent is that standing orders are to be used to improve a patient's access to naloxone because it eliminates the need for individual handwritten fax or phone prescriptions every time a physician or provider wants to prescribe naloxone for a patient. And because of the pharmacist's access issue, and pharmacists are incredibly accessible to patients, this gives pharmacists the opportunity to be very impactful in this particular area of healthcare. It's a collaborative approach in which the physician is still in charge in terms of prescribing the naloxone, and the pharmacist dispenses naloxone. However, the pharmacist is in a critical position in terms of recognizing the clinical need on behalf of the patient and then executing the standing order. So as I mentioned, the standing order was signed by the North Carolina State Health Director and authorizes any pharmacist practicing in the state of North Carolina and also licensed by the Board of Pharmacy to dispense the certain naloxone products to persons as directed in the body of the standing order. And we'll talk about those specific criteria for patient eligibility in just a few slides. As I mentioned, the pharmacist has to be an actively licensed North Carolina pharmacist. There is in North Carolina no mandated pharmacist training. There are specific criteria for dispensing the naloxone in terms of patient eligibility, and we'll talk about those in a few minutes. Specific criteria for patients to receive naloxone are specified in the standing order. And the pharmacist can dispense the naloxone formulation as specified specifically in that standing order. Now, some of the pharmacies prior to this statewide standing order were working under a locally executed standing order, and they can continue to do that. And they were notifying the provider when they dispensed naloxone to one of the provider's patients as a courtesy. And this can continue with the statewide standing order. The standing order, and there's a copy of it here, and it's also available electronically on the website www.naloxonesaves.org. But the standing order is divided into several different parts: the eligible candidates, the naloxone products that are eligible to be dispensed under the standing order, the directions for use, the refill criteria, any contraindications, the patient education that's required, the notification of participation by the pharmacy, and that is optional. And as I mentioned, the standing order in its entirety can be found on the website naloxonesaves.org. And DHHS has set up this naloxonesaves.org to be used to educate pharmacists and the public at large about the statewide standing order. And if you go to the general information section of that website, you can pull up a PDF copy of the order, as I mentioned, and I would encourage you all to look at it. Also, there's a section of the website under the naloxone user survey where patients can report the use of naloxone for an overdose reversal. And this again is optional, but it gives some mechanism for accounting for the impact of this naloxone standing order at the patient care level. And in addition, or lastly, all the pharmacies that are going to dispense the naloxone under the standing order are encouraged to go to the section entitled For Naloxone Dispensers and notify public health that they plan to do so. And this is optional, but it's strongly encouraged. So this is what you would see on the website, and on the left-hand column, you see the 4 naloxone dispensers. It takes you to this screen, and then you click on the highlighted section to notify public health that you're going to participate. And again, it's not a requirement, it's just being asked so that public health can keep track of the locations that are dispensing naloxone. And you can see over here the map, there's just a large number of pharmacies that are participating, and it's essentially free advertising, because a patient can go to this website as well and click on a specific flag, and then see where the pharmacies are in their area that are naloxone dispensers. And then lastly, under local treatment resources, we would encourage you to take advantage of any opportunity to offer and discuss local treatment resources for those with substance use disorders in order that they can be referred to and perhaps obtain treatment for the long term. Now, there's a lot of mythology around how naloxone works, so we thought it might be in order to give a brief overview of the pharmacology of naloxone and what its safety and efficacy profile. So essentially, we'll start at the beginning. Naloxone is a pure opioid antagonist that competes with and displaces opioids at opioid receptor sites. And this in turn temporarily, and that's a key term, it temporarily reverses any opioid effects, including opioid-induced respiratory depression, sedation, and hypertension. In terms of its competitive binding to these opioid receptors, it competes with morphine or any opioid. It has a greater affinity at the opioid mu receptor than morphine and most narcotics. But again, this binding is temporary. It was approved by the FDA in 1971. It doesn't have any psychoactive effects, no street value, no abuse potential, no effect on anybody that if they're not taking opioids. It's not a controlled substance. It can be administered IM and intranasally. If it's administered PO, it's not absorbed, and it does have a 12 to 18 month shelf life. If anyone has worked in an institutional care setting post-operatively, if someone perhaps is obtunded by overuse of opioids in the OR setting, if you've seen a naloxone reversal where the naloxone is administered intravenously, it's pretty compelling, and it is truly life-saving. In terms of its safety, adverse reactions are rare. However, when they occur, they're usually secondary to narcotic withdrawal, not the actual any sort of adverse effect from the naloxone. For the nasal spray, the most common adverse effect is local nasal irritation or soreness in the nose when it's administered. In terms of opioid withdrawal, severe opioid withdrawal can be induced if a patient is in an overdose situation and you administer naloxone. They may wake up and they may not be happy, but they will be happy later on when they determine that this administration of the naloxone probably saved their life. But besides the symptoms of opioid withdrawal are body aches, diarrhea, tachycardia, fever, runny nose, sneezing, hair standing on end, sweating, yawning, nausea and vomiting, nervousness, restlessness and irritability, shivering and trembling, abdominal cramps. So it runs the gamut of that entire spectrum. So as I mentioned earlier, the duration of action of naloxone is limited. So this is not a permanent intervention in terms of its lasting for its effects on reversing opioid-induced respiratory suppression. So it really just buys time to get the individual time to get the patient to the emergency department for further treatment and follow-up. Now, we'll switch gears and talk about the eligibility standards from the North Carolina Standing Order. And they're explicitly stated here for 9 different criteria. Essentially, and I won't go through all the specifics here. And again, these are available on the naloxonesaves.org website. But essentially, these standards gives the pharmacist pretty broad authority to implement a naloxone dispensing to a patient. Current history of heroin or non-medical opioid use, those are the substance use disorder individuals. Those who have high doses of opioids, if they're concomitant, number 4, you're talking about concomitant alcohol use, recent discharge from opioid treatment program, if they're entering a methadone maintenance treatment program, if they have opioid use through a legitimate channel, but they have concomitant renal dysfunction, hepatic disease, cardiac disease, HIV, COPD, or they're a smoker, or any other disease that might compromise their respiratory function, those patients would all qualify. And if they're in a prescription lock-in program, such as the Medicaid opioid lock-in program, that would certainly qualify them for the standing order. And then also patients who might, or their support system, who request naloxone and they have a family member or a friend who might be at risk for experiencing an opioid-related overdose, those persons would be eligible. And persons who voluntarily request a naloxone and are in a position to assist a person at risk would also qualify. So I think the intent of the standing order, because again the safety and the efficacy of naloxone when there is an opioid overdose situation, the intent of the standing order was to get the naloxone in the hands of the patients where it can do the most benefit. Now I wanted to take a minute to talk about a few concomitant risk factors in terms of the drug regimens of patients that might put them at even greater risk for opioid overdose. Concurrent benzodiazepine prescriptions with opioids can increase the propensity for overdose-related deaths, and we'll talk about that in a little more detail on the next slide. Patients who have multiple providers and use multiple pharmacies, check the CSRS. You can't tell by looking. Ronald Reagan in the 1980s in his dealings with the Soviet Union always used the mantra, trust but verify, and that's really what we're looking at here, trust but verify via the CSRS. And then one thing in terms of looking at the CSRS, patients who are in a methadone maintenance program where they go to the methadone clinic daily and get their methadone administered at the clinic, that methadone does not show up in the CSRS. It does not show up in pharmacy drug regimens in terms of cross-checking for polypharmacy and other risk factors for opioid overdose death. So that's kind of a hole in the system that pharmacists need to be aware of. As I mentioned, there's been some studies looking at the concomitant use of benzodiazepines and opioids. This one referenced by Dasgupta et al. In Pain Management, which was published last January 2016, found a 10 times higher death rate with this combination compared to opioids alone. Previously, there had been reports of a four times increase with this combination, but this study here set the bar pretty high. Just outlining the potential harm that can be done when this combination is used. And then there may be other medications and concomitant alcohol use, and you've got a potentially toxic cocktail. So problematic was this combination that in August of 2016, the FDA added a box warning to the labeling to potentially warn providers of the potential harms of using this combination. So I think that should go without saying that it really kind of laid down the foundation for pharmacists and providers and patients alike, that this combination was very risky and to be used only sparingly when it was absolutely necessary. And then there are cases where if there are opioids in the household, it's good to have naloxone on hand just in case. There are literally hundreds of these kinds of cases that I'm going to outline here where had naloxone been available and the situation been recognized as a potential opioid overdose in process, the outcome could have been much more favorable. But in In Fairfield, Connecticut, there was a report of a 5-year-old who stepped barefooted on a fentanyl patch that was left on the floor, and he went into respiratory depression. By the time they got them to the emergency room, he had died of respiratory depression. About 4 years ago in Burlington, North Carolina, there was a high school football player who, after a Friday night game, was spending the night with his grandmother, and he had taken some hits in the game. He was sore, and he found some methadone in his grandma's cabinet, and his assumption was, if it's safe enough for grandma, it's safe enough for me. Although, unfortunately, this young man didn't have a tolerance to the methadone that his grandmother had built up. He took that, and he passed away, again, from respiratory suppression. So pain medications are the single most frequent cause of pediatric fatalities that are reported to poison control. So this is a very serious matter, and again, we've got a potential solution to the acute problem of respiratory suppression. And now I'm going to turn it over to Dr. Cathy Huie to talk about the naloxone products that are available under the standing order, and some that aren't available under the standing order. So Cathy, take it away.
I want to talk a little bit about the time and take a little bit of time to review all the naloxone products. I think it's important for all of us to be familiar with these products, especially as pharmacist dispensing of naloxone continues to grow. The first product I'm going to talk about is the IM naloxone, which can also be given sub-Q or IV. It's been around the longest. It was approved by the FDA in 1971 and has the most layperson experience and the most literature available. The concentration is 0.4 milligrams per ml, and it comes in 1 ml single-dose vials and 10 ml multi-dose vials. These multi-dose vials are better suited for a hospital setting. Naloxone kits with IV naloxone typically include 2 naloxone 1 ml vials, 2 IM syringes with alcohol swabs, step-by-step instructions for responding to an opioid overdose, directions on administration of the naloxone during the overdose, and then gloves and possibly a mask. Advantages of this product are that it's the least expensive option. The North Carolina Harm Reduction Coalition has been distributing these kits for quite some time. And this naloxone is covered by most insurance plans. But a big disadvantage is that some people may not be comfortable giving injections. Because of the 1-inch needle length, it's not very useful for IV drug users because they prefer a shorter diabetes mellitus needle to prevent drug loss. However, seeing a needle can cause a former IV drug user to crave opioids. Next slide, please. The next product is another intramuscular naloxone that's available under the brand name Evzio. It was approved in April of 2014. It's a pre-filled auto-injector for IM or sub-Q injection, and each carton contains 2 auto-injectors containing a single dose of naloxone and a tester. Advantages are it's easy to use, it gives voice electronic instructions much like the AubiQ epinephrine injection. But its biggest disadvantages are it's very expensive. AWP is about $5,600. Average pharmacy price is somewhere in the vicinity of $4,000. It's non-preferred on North Carolina Medicaid, and most insurers are dropping coverage of this product due to cost, and it's not covered under the naloxone standing order. Next slide, please. Intranasal naloxone, now this is a generic naloxone. It's available in a 2 milligram per 2 ml pre-filled syringe, but it requires a nasal atomizer for use to be given to be used intranasal instead of intramuscular. So the cost of these atomizers are anywhere from $4 to $8 each. And this product was approved for IV, IM, and sub-Q use only, not IN use. This product was used by Project Lazarus, a community coalition in Wilkes County, which was established to combat the high level of opioid deaths seen in Wilkes County. The kit included 2 naloxone 2 milligram per 2 ml syringes, 2 nasal atomizers, step-by-step instructions for responding to an opioid overdose, directions for assembly and administration of naloxone. Its major advantages over the IM form are that it's needleless, it has a better cost advantage than the branded intranasal product. It's covered by most insurance plans. The naloxone for the kit runs approximately $50, and a kit with medication runs somewhere in the $60 to $100 range. Disadvantages are that it's very complex to assemble, which we'll see on the next slide, and then the nasal atomizer is not included. Next slide, please. So if you look at this slide, you can see that the intranasal naloxone takes 6 steps to get from opening the package to using the nasal spray. So it may be difficult for someone in a crisis to use. It was a temporary solution to the intranasal way of administration. Next slide, please. The branded Narcan nasal spray was approved in November of 2015, and it was released in February of 2016. This product is much easier to use than the generic intranasal formulation. You open the package, it's ready to go. There's no assembly required, and you do not prime this nasal spray. It's expected to extremely improve naloxone access due to cost and ease of use and universal pharmacy availability. It provides a 4 milligram dose, which is 2 times stronger than the generic intranasal formulation. And its biggest advantage is that it's ease of use because there's no assembly required. And it's a preferred product on North Carolina Medicaid, as well as many private and Part D plans. AWP is around $150 for the 2 sprays. So that tends to be a disadvantage because it is still kind of expensive for those that are uninsured. Studies have shown that the 4 milligram intranasal naloxone provided a 3.5 times higher receptor affinity at 2.5 minutes and a 6% higher affinity at 20 minutes than the 0.4 milligram IM dosage. And literature suggests that 50% of the opioid receptor activity is achieved by 1 milligram of naloxone by injection, but 2 milligrams gives 80% occupancy. There are some limits to the nasal route of administration. 17% of subjects who received intranasal naloxone were unresponsive but responded to an IV form. Nasal defects can cause an inappropriate response to the intranasal naloxone. Repeated use of cocaine or other opioids through the nose can cause destruction, scarring, perforation, loss of tissue, necrosis of the nasal septum, nasal mucosa, and its associated naso and orthopharyngeal tissues. So, a patient is contraindicated for intranasal naloxone use if they have nasal septum abnormalities, nasal trauma, nosebleeds, excessive nasal mucus, nasal damage caused by substance abuse, or if they have nasal congestion due to colds or allergic conditions which may interfere with drug delivery. Next slide, please. Now let's look at the various naloxone formulations and kind of compare those side by side. The IM dosage for both the generic and the brand product are 0.4 milligrams. Nasal Narcan, which is the brand name intranasal product, is available in a 4 milligram dosage that's to be given in 1 nostril. The generic intranasal dose is 2 milligrams, 1 milligram in each nostril. Intranasal absorption has been found to be as good or faster than the IM injection, and it works better with fentanyl or carfentanil-laced heroin or buprenorphine. The first week of October, the FDA met and are reviewing dosing guides for the community setting because there's many people who want to increase the IM dose above 0.4 milligrams. The reason for this is because EMS has reported that multiple administration of IM naloxone was required in 14.5% of patients in 2012 and 18.2% of patients in 2015. The North Carolina Harm Reduction Coalition has been giving out the IM kits, and most reversals have been seen through the IM use, though more experience has been obtained with the generic intranasal formulation over the past few years. Next slide, please. If we continue to look at these products, you can, as we've said previously, there's most layperson experience with the IM formulation, which is greater than 20 years. The generic intranasal product we've been using for the last 4 years. But if you look at this slide, you can see that the branded product has some definite advantages over the generic products. They can allow short excursions between 39 and 104 degrees, and they're less fragile because they're not in glass containers. The generic products are favored for the uninsured because of cost. Medicaid covers nasal Narcan and the IM and IN generics only. Evzio, again, is not covered by North Carolina Medicaid. Next slide, please. In 2005, Wilkes County, which is where I'm from, was listed as having the 3rd highest overdose rate per county, per capita in the United States. This is not a ranking that we were proud of. And so a group of community members formed the Wilkes County Chronic Pain Initiative. This group contained doctors, pharmacists, nurses, public health members, clergy, emergency department workers, etc. And our goal was to combat the overdose problem in our area. And we looked at a multi-step process. The first thing we wanted to do was educate. So we started out with education of providers and pharmacists, and we were encouraging providers to make sure they were looking at the controlled substance reporting system and to make sure they had access to it. At the time that we started, only about 28% of providers were registered for the database. But I'm proud to say Wilkes County was one of the first counties to have all practicing providers and pharmacists registered for database access. Providers were encouraged to require pain contracts of patients, to do random drug screens and pill counts, and to focus on the quality of pain therapy and not quantity. Wilkes Regional Medical Center's ED went to an all or none policy, which meant that pharmacies were to fill every prescription that the patient was given from the ED or not to fill any. And they went to a policy of only writing for 9 tablets for patients that were seen in the ED if they were receiving opioid therapy. Education of patients on the importance of opioid medication safety and use and correct use, and about keeping them out of the reach of others, especially children. And then we educated the populace on problems of overdose, signs and symptoms, and ways to prevent overdose. From this education step, Project Lazarus was formed. Project Lazarus is a secular public health nonprofit organization that formed in 2008 from this coalition. And we had the following goals in mind when we started Project Lazarus: to communicate with other members of the community, to help communities create and maintain coalitions that were similar to ours, to connect and build state and national resources, to build locally tailored drug overdose prevention programs, and to change prescribing practices. At the time, Wilkes County had a 30 to 40% higher prescribing rate of opioids than other counties. And to promote the use of Naloxone when it was available, we used the intranasal generic Naloxone, and we used the Evzio product, the branded product, which were given free of charge through grant funding to patients, caregivers, and those at risk of opioids, to EMS and to police. A collaborative practice agreement was established in 2011 with the Wilkes County Health Department to improve the availability of Naloxone access. And as you can see from the last statement here, the outcome was within 3 years of implementing our risk reduction strategies, accidental deaths from opioid overdose decreased by 72%. We went from 46 deaths per 100,000 residents to 14.4 deaths per 100,000 residents in Wilkes County. So we were definitely proud of our accomplishments. Next slide, please. Now we're going to kind of look at a case study. FC is a 41-year-old male with hypertension, COPD. He suffers from chronic pain due to a 2012 work-related accident. And his current medications include lisinopril 20 milligrams daily, Spiriva once daily, oxycodone acetaminophen 10-3 325 milligrams 4 times daily. And upon questioning, he states that he sometimes takes his wife's alprazolam at bedtime to help him sleep. So we need to determine a morphine milligram equivalent dose so we can see how this dose of oxycodone compares to the morphine dose, and so we need to see if he would be a candidate for naloxone therapy. We need to look and see if there's any diseases that might make him more susceptible. Describe a drug regimen, that any drug regimen concerns that we may see, and then if the patient is a naloxone candidate, what are some key things that we should make sure that we stress to the patient, and then what phrases and things should we avoid. Next slide, please. As you can see from looking at this slide, to calculate the morphine milligram equivalent of oxycodone, because that's what our patient was on, you use a 1.5 milligram conversion factor. Next slide, please. So if we take the 40 milligram dose of naloxone that the patient was on and we multiply it by the 1.5 milligram equivalent, then you end up with a dosage of 60 milligrams. And because that 60 milligrams is greater than the 50 milligrams, then he would definitely be consideration for the standing order. And we want to think, are there any disease states that he might be suffering from that would also lend for him being a naloxone candidate? Well, we said he suffered from COPD, and COPD, because of the respiratory suppression, again, is another thing that would make us think that he would be a good candidate. And then, are there any drug therapy concerns? Jerry went over all the problems associated with using naloxone and benzodiazepines, and this patient is suffering, is sometimes taking his wife's alprazolam at bedtime. So again, he would be a candidate for naloxone therapy. Next slide. Next slide, please. Okay, we need to look at the standing order. So what were our requirements? First of all, we need to look at risk factors. So what's putting a patient at risk for an opioid overdose? And then signs and symptoms of an opioid overdose. What does an overdose look like? And then the response steps. So what does someone do if they're near someone who's experiencing an overdose? And then we need to educate them on proper naloxone administration. Next slide, please. So signs of an opioid overdose include slow or shallow breathing, less than approximately 8 breaths per minute, or absent breathing. You may hear a choking or gurgling kind of sound or a snoring noise. The lips will be blue or gray, and the fingernails also, and the skin's pale or moist. And they're unable to wake up if you do a sternal chest rub. So if you're rubbing on their chest there where the sternum is and you can't get them to wake up, then it's very likely that they're suffering from an overdose. Next slide, please. There's various ways that a patient education spell out how to respond in an overdose situation. First of all, you need to make sure you recognize the signs and symptoms that we just went over. Then call 911. The reason you want to call 911 first is because if it's not an overdose, you want the EMS on their way. And if you call 911 first, then the person's likely, if they do wake up, to tell you not to call EMS. So this way the EMS is already on the scene so that hopefully they can be transported to the hospital before it's too late. And also, make sure when you call 911 that you tell the 911 operator that the person is not breathing. And it's better not to mention drugs or the possibility of an opioid overdose, stating that drugs are involved, because if you do, then the police have to clear the scene before EMS is allowed to enter the residence. So you just want to make sure that you're calling 911 first, and then if the 911 operator instructs you on how to do rescue breathing, then do as the 911 operator instructs until help can arrive. Next slide, please. It's very important that medications, especially opioid medications, are stored correctly. They should be stored along with any other controlled substance in a locked cabinet, drawer, or lockbox. They should be put away after each use and never left sitting on a counter. And patients should be encouraged not to share information about their prescriptions with anyone other than caregivers or others such as providers that may need to know. Make sure that safety caps are on all the bottles and that they're kept away from small children, and that they dispose of their old medications safely. They can return these medications if they're expired or if they're left over from a previous condition or they're no longer taking. They can take them to a DEA registered collector site, or most local police offices have collection containers also. Next slide, please. One thing we need to realize is this is a situation where pharmacists are not talking to a patient about a prescription that they're receiving. We're not educating them about that prescription. We're educating them and trying to convince them that they need a prescription. So we want to definitely avoid the stigma that the word overdose may have. Because if you talk to them about overdose, they may be thinking that overdose is only associated with drug addicts or drug abusers. So we need to make sure that the patient understands their risk for themselves or for a family member so that they know that opioids can slow or sometimes stop breathing. And we also need to make sure that we are approaching it with a non-judgmental, less scary language. So because this may be grandparents or the parents and think that overdose, again, only happens in drug addicts, and so they're therefore not at risk. So you might want to say something like, has your spouse ever mentioned to you that they're snoring or having been hard to wake up? Or, I want to improve your safety of your pain medications. Or, in case you have an unexpected reaction. Or you might want to even use the just in case and compare it to having a fire extinguisher at home, or maybe even an EpiPen if they have allergies. Now I'm going to turn it back over to Vera.
Vera, you may be muted.
Thank you. Clearly, naloxone is not the solution, but really it's a Band-Aid to this opioid overdose epidemic. But it is part of a comprehensive strategy that's now ongoing to help improve opioid prescribing and make it safer to help reduce opioid overdoses. So I'd like to briefly show you how naloxone fits in with recent state and national initiatives to attempt to address the root cause of this opioid epidemic. So safer opioid prescribing practices include for providers selecting patients and trying to identify which patients are at higher risk for addiction to opioids. As you've heard from the previous speakers, it's critical that providers as well as pharmacists check the North Carolina Controlled Substance Reporting System. Providers need to select appropriate medications, trying to avoid long-acting in many cases. There should be pain agreements, patient and family education should occur. There should be drug monitoring at the beginning and during therapy, and then patients need to be made aware of the realities of opioid overdose. Next slide. So the CDC back in March published guidelines for prescribing opioids for chronic pain, and aside from their first advice was basically avoid it if you can. That opioids, basically their risks far outweigh their benefits, especially for chronic therapy. But step one would be non-pharmacological, step two, non-opioid pain relievers, and then if opioids are required, again, urine drug screen before treatment, starting at the lowest possible dose, avoiding more than 90 milligrams of morphine equivalents, prescribing immediate release as opposed to long-acting, and then limit acute pain treatments, ideally to 3 days. Routinely, rarely should it be beyond 7, and as you heard, Dr. Huie mentioned that their ED only gave out 9 pills. Next slide, please. So patients who should be, according to the CDC guidelines, offered naloxone, and again, this mirrors what we've seen with our statewide standing orders, patients who have a history of overdose or substance use disorder, and especially those taking benzodiazepines with opioids. And those also at risk for returning to a high dose to which they've lost their tolerance, such as those released from prison. And the CDC mentioned their dose of risk to be 50 milligrams of morphine equivalents a day or more. Next slide. The National Pain Strategy was released a few days later, and this was a roadmap to care system where all Americans should be getting appropriate, high-quality, evidence-based care for pain, right? Because we don't want to then swing the pendulum so far back the other way that patients with pain are not being treated. And part of this National Pain Strategy was an educational campaign on the safer use of medications. And again, that included all the things we talked about, including discussing with family and friends how to recognize and respond to overdose, including the use of naloxone. Next slide. In North Carolina, specifically, the North Carolina released a strategic plan to reduce prescription drug abuse and mentioned how the timely availability of naloxone was essential. And obviously, about 3 months later, came the standing order for naloxone. The North Carolina Medical Board sends an email and letter to every single registered physician in the state, basically telling them that if they're prescribing opiates, they need to make sure that naloxone is readily available. And that's why, hopefully, the pharmacies that are participating in the standing order are letting the state know so that that can help providers direct patients as well to pharmacies. Starting next summer, July of 2017, all providers who prescribe controlled substances have a specific CME requirement. In addition, the North Carolina Harm Reduction Coalition finally got approval for needle exchange. And keep in mind, needle exchange programs typically also include helping patients access treatment. So these are 3 big initiatives, I think, in North Carolina. Next slide, please. So where we are today is basically we saw the CDC is recommending a broad range of patients be considered for naloxone. Our North Carolina opioid prescribers are required to ensure naloxone is available to their patients. We all know as pharmacists that if it depends on a patient seeing a provider to have naloxone, lots of patients won't have naloxone. And in our experience, even when providers wrote prescriptions for naloxone, only a very small percentage of those actually made it to the pharmacy. So it's important that now with the statewide standing order, as well as the local standing orders that have been in place, and then we mentioned third-party prescribing as well as liability, immunity liability, both civil and criminal. So at this point, we now have the tool. Pharmacists oftentimes may be the only ones that are aware that patients actually are using concomitant opioids and benzodiazepines, and we heard about the 10-fold increased death risk. While we're encouraging our psychiatrists to make sure when they're prescribing their benzos that they're checking to see if patients are on opioids and vice versa, the pharmacy is often the place where you all have the best opportunity to pick this up. And finally, the fact that we now have Narcan nasal spray available to every single pharmacy, then at this point it's available, it's an easy to administer product, no need for assembly. So we really want to bring home that community pharmacy is the key to really getting naloxone out there as much as we can into the community and help prevent these overdose deaths. Next slide. So as far as naloxone and the pharmacist, some best practices, and these came from Community Care of North Carolina that is working with their Community Pharmacy Enhanced Services Network. But in addition to dispensing naloxone, which we hope everybody will do, in accordance with the standing order, the pharmacist should also talk with the patient about different aspects of their prescription medication that increase their risk for overdose. So again, their disease states, they're borrowing other people's medication, etc. Definitely utilize the controlled substance reporting system as much as possible, based on judgment, of course. provide enhanced education to the patient and others on naloxone administration. And again, the person who is probably going to be administering the naloxone may not be the person for whom it's filled. So it's really important that they make everybody aware. As always, education about safe opioid and benzodiazepine or other controlled substance storage in the home is key, as well as safe disposal, again, because a lot of those opioids that start out legitimate end up in the wrong hands. And finally, it's a good idea, if possible, to communicate with the prescribers and or the primary care provider to make them aware that naloxone was dispensed. So that should help the providers out, because they're obligated to make sure that their patients have this aware. Next slide. So at this point, we would take questions. I did want to point out that the slides following this, if you can continue on, we did want to acknowledge Theodore Pakulis, who helped with this program immensely. Next slide. We have some resources, some links that you can go ahead and use. Next slide, please. We saw the slide on calculating milligrams morphine equivalents. Next slide. And this is actually from prescribetoprevent.org, which has great comparison slides with, next slide, NDC numbers and, next slide, ordering information for the different products as well. Next slide. And I think we're at our end. Thank you very much for participating. Have a great day.